Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Still on our discussion of the disease of the airways, we are going to be talking about airway tumors today. Now, primary tumors of the trachea and central bronchi are rare. In adults, the vast majority of tumors are malignant, while in children, most of the primary tracheal and central bronchi tumors are benign. Squamous cell carcinoma and adenoid cystic carcinoma are by far the two most common primary central airway tumors in adults. So we'll start off with squamous cell carcinoma. It's the most common primary tracheal malignancy, and it's strongly associated with cigarette smoking. The typical CT appearance of tracheal squamous cell carcinoma is a polypoid intraluminal mass. The contours of the mass can be irregular, it may be smooth, it may even be lobulated. The tumor can occasionally invade into the esophagus, and this would lead to a tracheoesophageal fistula. So in these images, we see a case of endotracheal squamous cell carcinoma. The radiograph shows a tracheal luminal narrowing here. You can see something is projecting into the lumen, causing narrowing at this level. Look at the caliber here compared to the caliber here. And on CT, there's an eccentric enhancing mass invading the left tracheal wall and markedly narrowing the tracheal lumen here. So this was a case of an endotracheal squamous cell carcinoma. Next, we'll talk about adenoid cystic carcinoma. We remember this is also one of the most common primary tracheal malignancies, and it's a relatively low-grade malignancy compared to squamous cell carcinoma. And it usually affects patients in their 40s. That's like a decade or so younger than the typical SCC patient. It's not associated with cigarette smoking, again, unlike SCC, which is associated with cigarette smoking. And adenoid cystic carcinoma has a propensity for perineural and submucosal spread, kind of like tracks along the wall of the trachea. And because of this, it may spread over a long segment of the trachea, complicating the ability to resect this lesion. The typical CT appearance of adenoid cystic carcinoma is a submucosal mass that infiltrates the tracheal wall and the surrounding mediastinal fat. Adenoid cystic carcinoma may also present as a circumferential tracheal or bronchial thickening that would lead to airway stenosis. So this image is a case of tracheal adenoid carcinoma, and it shows irregular circumferential thickening of the tracheal wall, causing tracheal narrowing. See how thick it is here, relatively less thick here, but it's still thick. It's kind of irregular and circumferential. This was a case of adenoid cystic carcinoma of the trachea. Then to carcinoid. Now, carcinoid almost always occurs distal to the carina. So while squamous cell carcinoma and adenoid cystic carcinoma are most commonly higher up in the trachea, as you go lower down below the carina, you should be thinking more carcinoid. CT shows an endoluminal bronchial mass. See, the bronchus is distal to the carina, and this mass may calcify, and it would often enhance avidly. Now, note that carcinoid tumors tend to have a larger extrinsic component than an endobronchial component. Now, in addition to carcinoid, the differential diagnosis of an enhancing endobronchial mass includes mucoepidermoid carcinoma, which is quite rare, and other very rare entities like a hemangioma in the bronchus, for example, and a glomus tumor, which is like a paraganglioma. All right, so these images show a case of endobronchial carcinoid. The chest radiograph actually shows a right lower lobe atelectasis. You can see this triangular retrocardiac opacity, which is different from the heart border here. You can see this opacity representing the collapsed right lower lobe. And the axial contrast enhanced CT shows a mildly enhancing, well circumscribed endobronchial mass here in the right mainstem bronchus, just distal to the carina. Yeah, this was a case of carcinoid. Now to mucoepidermoid carcinoma and lymphoma. First start off with mucoepidermoid carcinoma. It's a rare tumor that originates from tiny salivary glands lining the tracheobronchial tree, and that makes sense because as the name implies, it's mucoepidermoid. It's lining and it's mucus producing. So it makes sense that it's the salivary glands that are lining the trachea that are the source of this tumor. Now, they tend to affect younger patients, younger than adenoid cystic carcinoma, and the CT appearance is a round or oval endobronchial mass, usually indistinguishable from carcinoid. It looks just like carcinoid. Now, the next one is tracheal lymphoma, which is also rare, and this is usually associated with mucosa-associated lymphoid tissue molds, and this is also a very low-grade malignancy. Now to endobronchial mets: breast cancer, renal cell carcinoma, thyroid cancer, lung cancer, melanoma, and sarcoma are the most common malignancies to metastasize to the central airways. This image is a coronal contrast-enhanced CT, and it demonstrates a heterogeneously enhancing mass which invades the right mainstem bronchus. This was a spindle cell carcinoma, but the imaging appearance is non-specific. You can't just look at the image and conclude that it's spindle cell carcinoma. It is a mass in the bronchus, and if we have a primary somewhere else, it clues us to the fact that it could be an endobronchial metastasis. Tissue biopsy obviously would be needed for the final confirmation. Now, there are also some benign endobronchial lesions. Papilloma is a benign but potentially pre-malignant lesion that may transform into carcinoma. Suspected papillomas are typically closely followed because of this pre-malignant behavior. A single papilloma is usually caused by chronic irritation, but when you have multiple papillomas, like in laryngotracheal papillomatosis, this is caused by HPV, which may be acquired at birth. Now, the distribution is usually centered in the larynx, with tracheobronchial involvement in 1 to 5% of cases. Papillomas may also spread to the lungs, and when they do, they will form multiple cavitary nodules with dependent distribution. Another benign endobronchial lesion is a chondroma. Chondro is cartilage, so that also makes sense since the trachea and the bronchi are made of cartilage. So a chondroma is a benign cartilaginous tumor that rarely may occur in the airways. Other benign endobronchial lesions include schwannomas, which are of nerve origin, adenomas, glandular tissue origin, hematomas, hemangiomas of vascular origin, lipomas of fat origin, leiomyomas of smooth muscle origin. We realize that all these things we are mentioning can be found there and so can cause tumors in that area. Now, for a bonus, we'll mention what can also cause tracheal stenosis, but a focal non-neoplastic cause. So we'll mention mainly intubation or tracheostomy, and there's approximately a 1% risk of tracheal stenosis after intubation, but approximately a 30% risk of stenosis after long-standing tracheostomy. Other rare causes of focal tracheal stenosis include Behçet's disease and Crohn's disease. Thank you very much for your attention. Our next topic, this would be our penultimate topic in chest radiology, is going to be emphysema. If you are finding value, share, give it a thumbs up, subscribe if you have not, leave a comment, and I will see you in the next one.